Glad to see that we have a big we are going to split today's discussion up into kind of three different parts. And in between each part, we're going to spend a little bit of time taking questions after that section. Okay. We thought it was really important to get everyone together. We used to do these kinds of meetings at least once a year. And then I think during COVID, they kind of fell off. But it's important that we have the discussion so that everyone understands the decision-making process when somebody is in need of a higher level of care, each of our roles in that process, how the process works, and Christy will also be speaking about the financials. We want more than anything from this meeting today to provide reassurance that it is our team's sole commitment to keep people in as independent of a setting as they can safely perform at for as long as possible. And I really want to say the words out loud for some of the things that we have heard, which are inaccuracies. There is some comment made at times that we have a desire or motivation to move people into the health center sooner than they need because we want the real estate in independent living. That is not true. The health center, we also do not want to ever have full. We want to keep beds open in the health center because if and when you actually have a crisis, which can happen, and you need to go there, we need to make sure that that real estate is available. And that is our most important real estate. The process, as Sarah will explain, and I will add some more context to it, the transfer decision process to assisted living and Garden View in particular is a lengthy one. This is something that is discussed typically for months before a move happens. These are not emergency moves to those units. It's never the case. To skilled nursing, sometimes there can be an urgent need, as you can probably imagine. You know, a move to skilled nursing often follows a hospitalization or someone has a health crisis in independent living and they have to go to skilled. That happens much more rapidly. But the bigger moves that we really want to focus on today are those gradual transitions through the levels of care, and so that you can understand first how we try to delay those moves and the different types of interventions that we offer, Sarah's role in helping all of you to manage that process, how our team actually makes the decisions, how your physicians have a very important role in this. We'll take questions after, I think, each segment. So do you want to take it away? Okay.
Nope, not yet. How's that? Better? Okay. All right. Hi, everyone. I'm Sarah Leonard, the Resident Services Director. And before we really get into the details of transitions, I wanted to just take a couple of minutes and talk to you a little bit about who I am and what my role is here at Woodland Pond. There's a lot of new people, and I also think it's good to have a little bit of a refresher. So I just want to start by talking a little bit about what my background is and how I came to Woodland Pond. So I've been at this career with older adults for a very long time. I'm 46 years old, and my first job was when I was 14, and I started at Moran's Rest Home in Modena, calling bingo, doing activities, taking people for walks. And then I eventually became a personal care aide there. I helped people with showering. I helped people with dressing. I helped people with using the toilet. I was a housekeeper. I was a cook. I did some fence painting, a whole variety of things over the course of 10 years. And then after that, I left for college and I studied psychology and got a degree in psychology and a degree in art therapy. And throughout that study period, I always focused on older adults. And then I went off to graduate school, and again, my studies were on gerontology. And I got a master's degree in gerontology with a heavy focus on dying, death, and grief counseling. And from there, I went on into Manhattan and the Westchester area, and I was a private geriatric care manager for a while. I also worked at a luxury senior living facility as a case manager, and then as the director of resident services there. I worked for the Alzheimer's Association as a care consultant. So eventually, a lot of this took place down in Manhattan area in Westchester, but I'm a country girl and I love the Shawangunk Mountains, and this is the area I grew up in. So one day I was stuck in traffic in Manhattan. It took me over an hour on the Henry Hudson to get from Manhattan to Riverdale to my little apartment. And it was in that time that I said to myself, you know what? It's time to head back to the mountains. I've had my fill here and it's time to go back. So I did a Google search and I saw that Woodland Pond was being built. And then I saw this position was available, and then I was accepted for this position in 2009. So I've been here for 15 years, and it's been incredible to watch this place just grow and change, and it's been really something to be able to be a part of all of your lives. So that's my background. And now, what do I do every day that I'm here? What do I do here for you? So most of my position has to do with social work type services. So that part of that is working closely with Mary Jo, the wellness nurse, and I also work with Gretchen, the activities coordinator, on the lifestyle piece. So when someone new comes to Woodland Pond and they want to live here, myself and the wellness nurse do a really in-depth dive into their medical record and into their medical form that their doctor fills out, and we do an interview with them in person, and we review the medical record and we get to know them. And we get to know why they're looking at Woodland Pond and what they're looking for. So we have that interview process. The other thing I do is annual visits. And you just recently got a memo saying that I'm about to re-up annual visits. And the annual visit is an informal visit where I come to your residence and we talk for a little while. And you can feel free to share anything you wish about how you're doing, physically, emotionally, what your hobbies are, your interests. It's a time for us to just get to know one another. And I review your emergency packet. I also help when people go to the hospital. So if someone has a fall and they go out to the hospital, or they have a planned surgery, or they go for an illness, then typically myself or Mary Jo know this. And we learn this from the concierge or the security staff. So then I'll call the hospital, talk to the case manager, talk to you directly, talk to your family perhaps, and find out how you're doing and what you need. And if I find that you need a skilled nursing stay, then I'm in touch with the admissions coordinator in skilled nursing, who's automatically in touch with the case manager at the hospital, and they coordinate you coming to skilled nursing for your rehabilitation stay. So there's all this stuff happening behind the scenes to make sure that you receive what you need. So that's hospitalization. And then I also help people if they need to have a temporary private duty aid. And the private duty aid policy states that you can have a private duty aid for up to 4 weeks after an acute episode or hospitalization or an injury. So if someone's looking for a private duty aid for that short period of time, I can help them find someone. I also help people if they're looking for a certain type of specialist. If you're looking for an ENT, if you're looking for an ophthalmologist, any type of, or if you're looking for a therapist or a psychologist, I can assist you in finding those resources. And also if someone's looking for occupational therapy or physical therapy, then I can help by contacting your doctor's office. If you're having a heck of a time getting through to your doctor's office, I can help and get a script and get that handed into our rehab staff and help coordinate you getting some rehabilitation if you need that. I also work with people at the end of life. If their desire is to have hospice in their independent living residence, then I can help them with coordinating that aspect. And the other larger part of my job is just having an open door and having my phone always on, and people can feel free to just stop in and talk about how they're doing. Sometimes people come and they will be a caring neighbor and say, you know, I'm concerned about my neighbor. This is what's going on. Can you check on them? And I'll do that. Sometimes family members will call or stop by and say, I'm concerned about my mom. This is what's going on with my dad. What can Woodland Pond do to support them through this? And I'll sit and talk with them for a while as well. Sometimes staff will come to me and they get to know you very well. So they sometimes are aware if you're not feeling well, and they'll come in a caring and respectful way and say, this is what we're seeing, maybe you can give them a call. So I do, a lot of what I do is kind of just spontaneously happens, and it's just kind of going with the flow, you know, through the day as things come up. So now to the main talking points, the transition aspect. I just want to start by saying, the day that you sign your contract with Woodland Pond, you're signing a contract that entrusts us with your care. And that trust and that commitment is something that we take very seriously and we take to heart. And we're committed to your care throughout all situations and all stages of your life. And we will always do our best. Our goal is always to have you be as independent as possible for as long as possible, taking into consideration your health and your safety. So we're very happy to be here for you. And now Michelle's going to talk a little bit about PBS.
Before I do that, let's stop there for a few minutes and take any questions or comments on what Sarah has already shared. Or not. Okay. You wowed them. Yes. Oh, we do have. Here you go.
Thank you. My question is about the 4 weeks private duty aid. How do you come up with the idea of time frame?
So we can look at it on a case-by-case basis. The private duty aid policy is part of the resident handbook, so you can reference all the details in that. But yeah, I would say we look at it on a case-to-case basis, but that's the general time frame that we give, because the way we look at it is if somebody needs an aid consistently for a longer period of that, then that really points to the person having more challenges and very likely needing a higher level of care if they really need someone consistently over a long period of time. The exception to that is if someone's on hospice in their independent living residence, then they can have private duty aids up to around the clock if they need to have them.
As with a lot of the policies in the handbook, it does give discretion. It pointedly says, otherwise, if you need longer, whatever, you have the conversation with Sarah, and then we can talk about it on a case-by-case basis.
Hi, I wanted to ask you about the evaluation that you do when you accept someone coming into IL. I know Sarah said that she and Mary Jo meet with the people and talk to them, but I have witnessed over the years, and I've been here 11 years now, that not very often, but often, there have been people who have come into IL who are very easily spotted as inappropriate. And it turns out that within a very short time, you move them to another level of care. I guess my question is, why don't you have some independent physician or specialist evaluate the people who you're considering taking into independent? Something that maybe they have more skill at than just having a conversation. I know your doctor fills out the medical forms, but I also know that because we go to many different doctors and they don't communicate with each other, that very often your primary physician does not have all the information about what's happened to you over the last year. So I just make this suggestion that you would have some independent medical evaluation.
I can speak to that. So we have actually been working with the Welcome Committee, and thank you to everybody that participated in that process. We update our admission procedure every year. And since you came, Rhea, and many of you, this seems a little loud to me, we have added significantly more, now it's too quiet, significantly more steps to the process. So there's a couple of things at play. Number one, we cannot discriminate against anyone based on a healthcare diagnosis. So that's a federal fair housing and ADA federal regulation on us. So even if someone has a diagnosis of mild cognitive impairment, we cannot deny them housing and independent living. What we can do is reinforce the need to be able to meet our criteria for independent living. So if we have a concern about someone that has that diagnosis, The process now includes several steps. First of all, every new resident coming in has to have a mini mental exam done by their physician. They have to come in with it. Depending on how they score on that, there are additional steps. We may have them be required to see a neurologist. It says that in there if they don't currently have one. We also very often now are requiring any resident that we have a concern about to be evaluated by both our PT and our OT department. Because an interview is only as good as an interview. You know, years ago, for those that came in 15, 14, 13 years ago, the only people you met with were marketing. And marketing was very motivated to get you in here. And we nipped that in the bud a couple years in and said, we better get some other people's eyes on these folks. Because the financial model for Woodland Pond is predicated on you being in independent living for 12 years. So it doesn't benefit any of us if you accelerate through that process. The cost of care in the health center to Woodland Pond is much greater than caring for you in independent living. Our waiting list is always going to be there. We're always going to have people to move in, but the financial model wants you to be in independent living, maybe not the 12 years, but at least our goal is like, we think, are they going to make it 8 to 10 years in IL? But we only see it a snapshot in time. So we're bound by the ADA and the Fair Housing Law to not discriminate against people based on a diagnosis. We cannot do that for residency. So then we have to go to these next steps in the evaluation to maybe have them see a neurologist, have them be evaluated by PT and OT, because we share your same concerns. We want people to be here for as long as they should be and be able to thrive in independent living, because this is not, you know, independent living is not a nursing home and it's not assisted living. You want to come here because you want to be able to enjoy the riches that independent living has to offer, right? Whether that be companionship with your neighbors, sense of safety and security, access and use of all the amenities. So that process has evolved quite a bit, Ria. We also require anyone that's seeking life care, in addition to those steps that I just outlined, they all now also have to get blood work and give it to us. A lot of you that didn't apply. So the Welcome Committee had asked to have an opportunity, I think at the beginning of the summer, to review our process and make any recommendations to changes, because they have expressed the same concerns. And they were very, very kind and supportive of the most revised process. One thing also to keep in mind is we know that a transfer in a level of care, whether it be from your home to Woodland Pond or within Woodland Pond, that can be a very unsettling event. And so a lot of times you'll see people that come in and off the bat, it seems like they're really fish out of water. But then we support them. We keep a check-in on them. We support their families. And most of the time we see, if not a full improvement, then a gradual improvement. Because most of you are in the same boat. A lot of you have come from a home that you've been in for 30 or 40 or 50 years, and you have your routines. And then all of a sudden you're smacked down into this community, communal living, people you don't know, a giant building, 75 pages of handbook policies. So I think it's just about the most important thing, you know, and one of the things that makes Woodland Pond so distinct is, whether you realize it or not, you care about your neighbors, right? So if you see, and you know your neighbors, you know their habits, you know that this person seems like they're off. Going to Sarah or Mary Jo or me is always a discreet process. We never say, you know, Liz told me that she thinks that, you know, you're not showering or whatever. But Sarah will, I'm just using you as an example, Liz. Liz has never done that. But Sarah will go and she'll do the sniff test. I mean, it's definitely part of the process. I mean, when Sarah goes on these annual visits, she can pick up on things like if your apartment or cottage smells like urinary incontinence, or maybe you're not taking care of your pets or whatever. That's all part of it. It's all sensory. Jason's team is a huge role in helping us to know if this person's more confused when they go out for appointments. And none of this is to get anyone in trouble. It's because of exactly what Sarah said when she started. You selected a community like Woodland Pond with a care team because you wanted to be cared for life. Sometimes that means we're in your business. We can't care for you if we don't know what's going on. You know, we can't, we never want to put you in a position of disclosing something that you're uncomfortable disclosing, but we need to know what's going on so that we can support you and help you. You didn't want this to be a burden to your children in a lot of cases, or you didn't want to have to deal with it on your own. So you selected us versus just some 55+ apartment complex because you wanted the care. And so this is what we're trying to do. So what happens when residence changes start to occur? Every Tuesday, now at 1 o'clock, it used to be at 11, but you'll see a whole team of us in the classroom every single Tuesday at 1 o'clock. And what we're doing at that meeting is we are talking about everyone in the community that is experiencing some possible level of care change on the horizon. Sometimes people stay on that list and are part of that discussion for a year. Sometimes it's 2 months, but it's every single week. We go through the list and we talk about how is this person progressing. Oftentimes, actually the meeting, the way the structure works, so just so you know who's there, because this is a very important team for you to know. This is the interdisciplinary team, okay? The interdisciplinary team is myself, Sarah, Mary Jo, both of the social services staff members from the health center, Philip Mail, Debbie Vining, who's our director of nursing, both unit managers for the health center, nurse unit managers, Jonathan Papan, who is our director of rehab, and Natalie Russack, who is our admissions coordinator for the health center. This is a sacrosanct meeting. It never gets skipped ever. And if I'm home working or off, I will call in because we have to make sure that nobody gets left behind. So we go to these meetings and we talk. And Sarah always opens the meeting. The first list is always independent living people, okay? And Sarah will say, you know, right now I have concerns about, and then we go through the list and she'll explain, here's what we're observing, here's the different kinds of things that I've talked to this person about. And I don't know if Sarah plans to talk about this or not, like the different interventions, or should I cover it? Okay, so the way that this works is always we get a hint, either we observe or we're told, Sarah, I think you need to check in on so-and-so. She seems to be struggling more than they were before. So she'll go and have a visit, have a chat. She will look to see if you have signed the Healthy Connections form, which is the form that gave us authorization to look at your medical records. So we'll buzz through that and just see if there's anything new health diagnoses. She's trying to really get a comprehensive understanding of where you're at. And then we'll try to figure out, you know, kind of what are some of the challenges. Oftentimes, these early discussions include discussions with the children or adult family members. And the things that we start to see first are typically trouble with medication management, a need increased falls or balance or range of motion issues, or somebody might newly just show up one day with a walker. All of those things are things that we want to try to attend to while you're still in independent living. So if you're having trouble with medication management, totally understandable. A lot of you are on many medications that need to get taken at different times of day. Sarah 100% can and oftentimes has helped you get a tool, and there's different levels and different types of tools to allow you to manage your medications independently, but in a way that gives you confidence that you're not hurting yourself by missing or doubling up on meds. There's lots of automated systems. So that's very commonly an intervention that Sarah starts with if someone's having trouble. And it may not seem like that big of a deal, but a lot of times, if you're not getting the right meds that you have been ordered, they can have cascading effects in terms of how you're functioning. So we always want to look at med management. And then we want to make sure that that's being attended to. So that's low-hanging fruit, and Sarah helps with that all the time. The next thing, and Sarah alluded to this, another step that helps you stay in your home as long as possible is making sure that you're physically strong, able to traverse from your home to the things that you want to do here at the community safely. You can do your independent home management. So are you able to do your laundry? Are you able to reach and get a glass? You know, very simple things. And for that, you all have benefits under Medicare that will pay for outpatient physical and occupational therapy. So that would be the next, one of the very normal next steps. Very, very common. Sometimes there's a need for an aide, okay? And maybe it's just that you need help getting groceries, okay? That we wouldn't even put in the category of the 4 weeks. We don't have an issue if you need somebody to come in and get you groceries. We totally understand that. But if that allows you that added level of independence, totally okay. It's just important that Sarah knows that that's happening, okay? This all then progresses, right? Aging marches on. And so if we have exhausted all of these interventions and we have concerns, these concerns are discussed at the interdisciplinary team meeting. When we evaluate residents, there are independent living criteria. You all should have seen those. I will have Lindsay send out the updated list. It hasn't been updated since I sent it in June, but just so that you have it. It used to be that the list was just one long list. When we updated it in June, we split them into, these are the important things, and then these are the really important things, right? Because you don't have to pass or fail every single one of those things to be considered a need for a higher level of care. But we're more concerned about things like safety-related issues than we are about whether or not your daughter is helping you with your finances, right? So needing help with finances is on the list, but that's not going to be something that's going to just qualify somebody on its own from being an independent living. As long as Christy's getting paid and we think your bills are getting paid and the tax collector isn't here, then can you just shut my phone off? Then that's not as important, but we look at the complement of everything. And then when I send this list out again, I want you to pay attention to the items on the bottom, because the items on the bottom are the really crucial considerations for independent living. And you will see the theme is that it's focused on safety and health, right? So if all of a sudden you used to go for a walk and then several times this week, somebody on the maintenance team or grounds team found you out on the property somewhere and you had no idea how to get back, that's going to be a major concern for us. If you are consistently having incidents where you're not wearing your PERS alarm, or if we have a concern that if a fire alarm goes off that you don't know what to do, these are the things that really start to concern us. Also, there is a level of care in independent living that is not access to nursing and social services support 24/7. So if you are someone that multiple times a day needs Mary Jo to go up, and that's been happening consistently over and over, and it's not because of a specific health incident, it's just you're requiring that level of intervention and support from our team, you're no longer most likely independent, qualifying for independent living. So what we do is we talk through all of these things at our meeting on Tuesdays, and then once we start thinking that there's a need for a higher level of care, Sarah has had those conversations and begins having those conversations with the resident and with their family. Okay, we want this to be agreed to by consensus. The goal is always to come to a consensus that this is the right thing to do. It's never something that's heavy-handed. So sometimes that takes time. We have had moves that literally we think this person probably needs help. We go talk to them. They're like, yep, I'm ready to go. The kids are like, yep, he's ready to go. And it happens with as quickly as we can get the doctor's paperwork signed. There are others that don't see what we see. And so those are the more challenging moves. And, pursuant to today's discussion, it's important for you to understand that in your interactions with one another, you may not have the full set of facts as to how this person is functioning behind the scenes, right? So you may see that this person can come and have a hell of a dinner conversation, but you don't know that they're calling Mary Jo 3 times a day or needing us to go help them plug something in the apartment and need somebody from Jason's department every single day. And we don't disclose that to you. So when there are situations where somebody moves or is recommended for a move and you think, oh my gosh, this person is totally cognitively intact, maybe so for conversational purposes, but we have criteria and we review them objectively. In your contract, not the handbook, but in your actual contract, it tells you that the decision for making moves to higher levels of care are the decision of the interdisciplinary team. You've agreed to that when you've come here, but it does allow for an appeals process, okay? And fortunately, knock on wood, in 15 years, we've never had anyone appeal. Eventually, because these are such protracted moves, and there's a lead up to this. It's never a Band-Aid getting ripped off. We're able to eventually get everyone on the same page that this is the right thing. So when it's determined that a move is ready to happen, there are some specific things that have to happen. First and foremost, while Woodland Pond makes the recommendation, Woodland Pond does not have the regulatory ability to sign the paperwork that you need to go to assisted living or memory care. That has to be signed by your physician. That's a state law. So we can recommend it all we want, but at the end of the day, the actual piece of paper that says this person needs assisted living or memory care comes from your personal physician. Okay. And that form, which is called a New York State Form 3122, it doesn't matter. It's 3 pages of asking the physician questions about your activities of daily living, toileting, hygiene, nutrition and dietary management, ambulation, transfers, the whole thing. Like, how are you managing your day? And the physician has to fill that paperwork out. It also asks the physician specifically, the very last box on that form is, and I'm paraphrasing, does this person qualify for an assisted living level of care? So your physician has to be on board with this too. That form is required, and it has required to be completed within 30 days of your move. So it can't be stale. So we're getting you up to this point gradually. And then we're getting to the end and we're saying, okay, now it's time to go to the physician. Your physician gets the final say. And I think that when residents understand that comprehensively, I think that's a big part of why we haven't had any need for appeal. Because I think the residents understand that if the Woodland Pond team, which is very experienced in this, I mean, you just heard Sarah's background. I honestly didn't even know that she had all those credentials. I just thought she was really awesome. You have a team of people here that have been doing this for a long time. And we completely understand and empathize with the fact that a move to a higher level of care is very hard to accept. It's physically hard because you have to downsize again. It's scary. It's another step towards death. But as Sarah will, I think, take over now and talk about what we see time and again, once those transitions are made, is the person in many ways thrives. Because the thing that you were struggling to keep up with and that was diluting or diminishing your day every day in independent living is no longer a worry. Do you want to take it over from here?
I think I'd just like to touch base on what the conversation is like and what it's like to have that initial conversation to open up a discussion about possibly making a transition to Woodland Pond. So when I go to do that, I always meet with people one-to-one and just open it up and say, what are your thoughts about assisted living? and I go over what the benefits of assisted living are and the different services that are available there. And consistently, I'm met with hesitation, resistance, and anxiety. And that's something that I expect, because when I put myself in your shoes, I think I'd feel the same way. Because assisted living may be an unknown to you. It's something that you may have misconceptions about or misinformation about. And just as when you moved here and you experienced different levels of stress and anxiety with downsizing and coming to a whole new place with whole new people, it's a similar thing moving into the health center. New people, new situation. So I take that to heart, and I do my best to have this conversation in a sensitive way. And so typically what I'll do is invite someone to come and take a tour with me, and let's look at assisted living, let's learn about it. And that gives someone the opportunity to see different apartments in assisted living, to meet people who live in assisted living, to hear directly from them what their experiences in assisted living are like. And that's always very helpful. People can also attend activities there. They can go to the dining room there. They'll meet the staff. And it's really interesting because whenever I do this, most of the time people say to me, oh, the dining room is much nicer than I expected. The rooms are small and that's challenging, but it's interesting to see how different people set them up. And it's actually better than what I thought it could be. You can fit more in here than I realized. And they meet the staff. And the number one thing that I always see is people look around and they say, I know just about everybody here. And the reason you do is because everybody in assisted living is from independent living. We are one community under one roof, just sleeping in different residences and some people receiving more care than others. And to me, the great thing that I see in assisted living is it winds up being a great balance for people. They have the balance of being independent. They can do whatever they want. They can go wherever they want in the community, but they have the aides and the nurses around the clock to help them if they need it. And it's not that the aides and nurses are helicopters hovering over their head and constantly checking on them. They're there to assist with what somebody needs. Maybe it's laundry, maybe they want 3 meals a day, maybe they need help in and out of the shower. There's a whole variety of reasons that people go to assisted living, and I don't think two people go with the same reasons. So I just want to touch on that aspect of the process. So typically, the process takes many conversations over time, and typically the person I'm talking to goes through a whole range of emotions, which is natural and expected, as I said. And we always have the focus of, like Michelle said, coming to consensus and coming to some level of acceptance that this transition needs to take place. And what I do see, and what always makes a challenging conversation and a challenging, potentially, transition process worthwhile, is when I go and see the person later, or I hear from the staff or from their family that their anxiety is less, their stress is less, and they are enjoying their life more because they are not struggling throughout the day to take care of their basic needs. They're not stressed out about their meds. They're not scared about getting in and out of the shower. It just allows people to have a quality of life so they can keep on enjoying what they are doing. And that's the beauty to me of the CCRC, is when you get to see somebody get what they need and really thrive. So that's just to touch on what the process looks like. Any questions for me on that aspect in terms of the conversation? Yes. Okay.
I was wondering, I haven't heard much said about the the rules for husband and wife in the interaction of the decision.
Mm-hmm.
Could you elaborate on that?
So there's many different scenarios with assisted living and Garden View and skilled. So sometimes when there's a couple, there may be one person who is receiving the care and the other person's the caregiver. And in that situation, typically what occurs is the caregiver will eventually come to me or come to the wellness nurse and say, my level of stress is so high, I'm not sleeping well, I'm not eating well, I don't know how much longer I can take care of my wife, we'll use as the example. And when someone comes to us about that, then we take action. And then we start the process to figure out what the best level of care would be for their wife. So in that scenario, one person stays in independent living and the other person moves into the health center. We've also had scenarios where a couple moves together. And in that scenario, sometimes it's that both of them need the same amount of care, or sometimes one needs more than the other, but they both can benefit. So we're able to have them both go into assisted living. And in that situation, sometimes it takes the caregiving spouse a while to come to the point of acceptance that their wife may need to make a transition, because it's hard. Some people really hold on and feel that they need to take care of their spouse until the very end. But sometimes that's just not possible because it's very challenging and it's very hard. So in that case, I will typically keep in touch with the caregiver and just check in every couple of weeks. How are you doing? What do you need? What can Woodland Pond do to support you? But if I see that that person is really starting to decline, that's the caregiver. If they look really tired, if we're not sure if they're eating really well, if they're reporting they're just not getting any sleep and they're totally losing their patience and very frustrated, then I will nudge a little bit, push a little bit and say, maybe you want to talk to another couple who have gone through the same thing. Maybe you want to talk to another husband who's experiencing what you're experiencing, who's already moved their spouse, and hear what they have to say. Because there's a wealth of experience here that can be tapped to help someone through a transition like that. Does that answer your question? More or less? Not really? The what? And with the emotional side, we recently had a group, a peer-led caregiver support group. And that, I understand, has been very successful. And that's a group where it was caregivers who are residents who are taking care of their loved one or spouse, coming together to talk about their personal experience and provide each other with emotional support. And that group, I've heard, was very successful. And so that's, I think, a key in the emotional aspect is to reach out to peers and also possibly reach out to a therapist or a counselor to talk about the feelings that you're experiencing. Mm-hmm. Yep.
Yeah. So I'm Joyce, and I just recently made the transition from IL to skilled nursing. It happened very quickly, and it surprised me because what happened was Sarah, I think, had noticed that I was having more difficulty walking than I had when I first came to Woodland Pond some months before that. But you were talking about the primary care physician being very important input in a person's condition. And I wonder if there isn't somewhat of a conflict of interest when the primary care physician is Dr. DiNapoli, who is the resident physician at Woodland Pond. So that strikes me as a little confusing because he's now my primary physician. And isn't it to his, not exactly advantage, but doesn't he have a stake in having me be in skilled nursing rather than in independent living? I don't know.
Well, Dr. DiNapoli is the medical director of skilled nursing. So as soon as somebody goes into skilled nursing, he automatically becomes their primary care physician while they're in skilled nursing. So I haven't heard of the scenario before of him already being someone's primary care doctor, and then they go into skilled nursing and he continues to be their primary care doctor. But I don't think from a contractual standpoint or from what he does as a doctor that he's gaining anything additional if he's already your primary doctor on the outside.
Yeah, no, he's just my doctor here.
Right.
I never met him before coming.
Yeah, no, I don't think he gets paid the same whether you're whatever level of care you're in. He's not gaining anything from making people, go to one place or the other. Tamar.
Yeah, that's it.
Yep, Jason's coming.
Sarah, can you say a little more about the role in independent living of companions and aides and CNAs? And I know there's some feeling that if someone can only stay in independent living if they have full-time care, that gets looked at like there are certain limits. I know at hospice it's full-time. Could you elaborate a little bit?
Right. So as we touched on before, the private duty aid policy is that people can, have an aid for a temporary basis, usually up to 4 weeks after a hospitalization or after like a surgery or acute illness or something like that. But as we said, once it goes beyond the 4 weeks, if we're seeing that someone needs it consistently, then we look at why they need the person. Is it, as Michelle mentioned, is it just for grocery shopping, or are we talking about it's for dressing and showering and a whole bunch of different things that really cue us into them needing a higher level of care? But you'll see aides for different reasons. There are a number of people in independent living who are on hospice who have aides with them, and they're permitted to do that. Let me see what we're... Oh, one more.
Yeah, one more question I have, and this is probably my fault for not having read the pertinent handbook cover to cover. But I'm unclear about what my responsibilities and rights are as a patient, a resident in skilled nursing. Sometimes people are surprised. Oh, you go out. You can go out. Can I go out? Can I spend the night in my cottage? Do I, just what are the limits and what are the privileges?
Mm-hmm.
That's something I'm confused about.
Yeah, so there is a list that you can get at skilled nursing that's called basically that, resident rights and responsibilities. And that lays out very clearly what your rights and responsibilities are. And in terms of outings and things like that, you can always talk with Jasmine, or who's the new social worker again? Amber. You can talk to Jasmine or Amber. They're on the social work team, and they can go over with you, Joyce, about what you're able to do in terms of staying overnight in the cottage and going out and so forth. Always ask questions. Always find out what you can do, because we want to be as little restrictive as possible. Are any other questions for me? Okay.
Hi, everybody. Christy Battistoni, Director of Finance. And I'm here to talk about the costs when people move permanently to the health center. When you move to the health center, you're either going to be a private paying resident or you have life care. When you're private paying and you go to either assisted memory care or skilled nursing, those private pay costs are anywhere between, right now in 2024, $6,900 and almost $16,000 a month, depending on what area you are. Many people that don't have life care have long-term care insurance. We, as a courtesy, do bill that long-term care insurance, your long-term care insurance policies out for you. We have you pay your bill, but then we submit to your long-term care for reimbursement to you. Also, sometimes when there's in a spousal situation, if somebody is in the apartment and is paying privately, this is not by contract, but we've always given the person who's in the health center a 25% discount to help with the costs there. So that's basically private pay. As far as life care goes, when you have life care, that means that when you go to any of the areas in the health center, you are going to be paying your monthly service fee as it was related to your apartment. So if you're in a Cedar and you're paying $6,000 a month, that's the fee that you're going to be paying in the health center wherever you are. And then on top of that, there is by contract a charge for meals, 2 additional meals a day. So basically, we charge $20 a day on top of that. So about $600 a month is the meal charge on top of your monthly service fee if you're a life care resident. When you go to the health center, you sign a new admission agreement over there that kind of details everything that you're going to be paying. You are expected to maintain your renter's insurance for whatever unit you are in over there, like you had in independent living. There's also, similar to kind of the fee sheet that for like bus trips or cable TV, internet, all those types of things would be at your cost. So those you're responsible for in addition to what you're paying. If as far as going to your doctors, labs, those types of things, you're all supposed to be maintaining your own health insurance. So that would be billed out and you'd be responsible for co-pays, et cetera, like that. So all that is very similar to independent living. Does anybody have any questions regarding that? Ralph?
A couple.
Sure.
One goes to healthcare center, the other one stays home. What does that cost?
Okay, so if 2 people have life care and one is in the apartment and one is in the health center, it's going to be, you know how you have a first person fee and a second person fee? It would stay the same. You would have the first person fee and the second person fee, but you would have the meal charge on top of that. So basically everything would stay the same except the additional meal charge with a couple that's both on life care. We have a lot of couples who one has life care and one doesn't. So it depends on where the one is that doesn't have the life care. If that person is in the health center, they're going to be paying privately. And then the person that's in the apartment would be paying the first person monthly service fee. Ronnie Sue's up here.
What about trips to doctors, specialists, whatever, and ambulettes are called, or Woodland, or one of Jason's bus drivers? How is that billed?
So if you need to have an aide go with you, there is a charge for the aide. Otherwise, there isn't a charge when you're going from the health center to any medical appointments. Right, as long as it's on the scheduled
Which
date.
is the same as in IL.
So to that, Ronnie Sue, so our aides cost more than private duty aides to go out. So normally if you're someone that needs an aide to go with you, and we don't require an aide to go with everyone. Some people are perfectly fine going out to appointments by themselves. They just need the transportation. We always recommend to you to hire your own aide because with the cost for us to pull them off the unit and the adding in their benefits and the fact they're normally on overtime to do that, our charge is $65 an hour, right? $60 an hour for our aides to go, but the average cost of a private duty aide is like $25 an hour. So we have a long list of people that do private duty aides, and we always want to get you with a private duty aide. It benefits us to keep our staff on the floor, and it benefits you financially. So we always routinely make that recommendation.
Or a family member, right? Because that
Or a
way,
family
if
member.
you have a family member to take you, then you don't have to pay any additional charge.
And one thing that happens sometimes for independent living and folks in the health center is maybe you can get on the bus independently or with our help, and then your family member meets you at the appointment. So they don't necessarily have to come here and ride on the bus with you. I think Ed LaPerche had a question. If you, oh, no question? Oh, it's covered.
Eileen.
I don't understand the rationale of if you're in I'm in a 2-bedroom apartment. So if I'm in a 2-bedroom and then I'm moved over to the health center, my fee would be higher than somebody in a smaller apartment. But neither of us would be back at our apartments, right?
Right, that's correct. So this is typical and standard in the industry. And the reason being that you're choosing to be in a larger apartment now because you want that quality of life. The deal for everyone is exactly the same. Whatever you pick in life is in independent living is the same cost that you're going to incur when you go to the health center. So one of the things that we see is as people kind of come to a conclusion that maybe I don't need so much space, I'd like to drop my monthly service fee, you will see oftentimes throughout a particular year, if we have available inventory in the smaller units, we'll make that available first to existing residents that want to downsize. Because you have to downsize before a move in order to qualify for that lower payment. So many times, especially if Christy knows somebody's having maybe some financial concerns, we will keep and work with marketing, even though we have people waiting in line from the outside to take every single unit here. If somebody internally can benefit from a downsize, then we always try to make that happen. So in a particular year, I'd say generally the last couple of years, we've had at least 3 downsizes on average every year, and people really benefit from that financially, and then it carries forward to the health center. So we work with you. Yeah, definitely. Okay.
Mr. Breyer first.
Perhaps this is an arcane question, but Michelle, you sent out a note the other day regarding the potential financial risks of Medicare Advantage plans. And there, as I read it, there are potential implications both for the patient and for you. Have you noticed any change in the approval rate for higher levels of care from the Advantage plans that have effect on what the resident has to pay or what you can collect from them?
So absolutely the answer to that is yes. And it's no different now for us than it has been since we've opened. What has changed is the Medicare Advantage plans are more and more popular and more pervasive with plans from retiree plans, right? So I'll use IBM as an example. A lot of you were affected by this, my parents, Christy's family. So until 3 years ago, 3-ish years ago, 4, you had the option of sticking with full Medicare and a supplemental plan with IBM. Then a couple of years ago, they announced that you had to take a Medicare Advantage plan. They switched all of their retirees into Medicare Advantage. And I had told my parents from day one, never take a Medicare Advantage plan because they get you with their marketing and they say, we're going to pay for dental, we're going to pay for glasses, you're not going to have any premiums. But the minute you actually need them, you have put your entire care decision-making in their hands because they're all HMOs. So we see it time and time again. We have a resident that's coming into skilled nursing today that has a Medicare Advantage or an HMO plan, just like a Medicare Advantage plan. He had a stroke. He has a prolonged need for rehabilitation to be able to go back to his home independently. They are going to require us to give them updates every 3 days. Every 3 days. And the chances of him getting more than 14 days is slim to none. Traditional Medicare, our team makes the medical necessity decisions. And nobody from traditional Medicare is coming in. It's not an HMO. So we have to treat and care to their standards, but they don't get to make that decision. So in the case of someone that the HMO is cutting, we have seen on more than one occasion that the HMO says, we're not paying you anything anymore, Woodland Pond. But our medical director, Dr. DiNapoli, and our interdisciplinary team says, this person is not meeting the criteria to go back to independent living yet. They need more rehab, right? So then what happens is you're all here, right? You're contract holders. We're not kicking you out of the bed, but your costs could change. And what will 100% change is how much rehab you're getting. Because when you're on a Medicare stay or Medicare Advantage stay and they're paying, you get up to 3 hours of rehab every day. Once that goes away, the most you will qualify for under the outpatient, even if you're in a bed, is 3 times a week. So just calculate how much longer your rehab is going to take if you're up to 3 hours a day, dropping down to 3 times a week. The plans are terrible. We have seen some of you have very fortuitously made the decision to switch from a Medicare Advantage plan into Medicare. I see some shaking heads. And you really see the differences of experiences. One thing to know, and we've already given you so much information, I know it's hard to absorb, but we're going to take a couple more questions and then break up. But there is a provision under Medicare that if you have a Medicare Advantage plan and you get admitted to skilled nursing, you can switch upon admission. And our team can help you with that.
So it doesn't have to be during open enrollment time.
Right, so it doesn't have to be during this current open enrollment period. It can be any time during the year. So if we think that you are going to have a prolonged need, let's say you had a severe stroke and you don't have mobility, you have some kind of hemiplegia, and you have a Medicare Advantage plan, very likely our social services team is going to be going to you and your family and saying, we've got to get her switched. If it's something that we think is quick, you had a total knee replacement or something, normally you can rehab in 2 weeks and go home. That might not be as critical, but we will work with you on that. We are here to help you in all of these aspects. I'm going to take 2 more questions. I've got,
Helen?
okay.
Ed, I'm coming.
We got Ed, and I think we have Jeffrey, and then Margaret, and then we're done.
Yes, the IBM plan is confusing from the standpoint that I have a Medicare Advantage plan, but it's a PPO. There are choices within that decision-making.
But they're still making, ultimately, regardless of which physician you pick. So the difference between that and a traditional HMO is they just have a bigger provider network. But once you're here, they act exactly the same. They're still going to require updates every 3 days, and they're going to make the medical necessity decision. And that was the purpose of me sharing that article. Because not only do we see it experientially that the care is cut or denied, the Senate is concerned enough about it to be looking into it. And we understand that a lot of you financially benefit from having the plans that your retirement plans offer you, which is why we make these recommendations while you're here. But then if you get into skilled nursing and we think that there's a significant risk to you, we really try to help you switch. And then I think you can switch back.
I think you can switch back. I think you can switch back.
Well,
No.
the problem that's.
No, you can't with IBM. Once you're out, you're out.
The problem that I'm having right now is physicians are retiring right and
Yeah.
left.
Mm-hmm.
And trying to find a new physician as your primary caretaker is really a problem, and especially over here. I have 2 possibilities that I've come up with. And quite frankly, Woodland Pond is not helping with that. There is no list anymore of providers that can
We
be
have a
called
provider
upon.
list, don't we? We do have a provider list, but we also have a physician practice.
I've
access.
been asking for that, and I've been told it does not exist any longer, that there is none.
Okay, so we can resurrect that, but we do have a physician practice that we partnered with 2 years ago that is taking new patients for primary care and sees them at Woodland Pond. It's Access Medical. So I can't answer as to who, maybe didn't convey that to you, but we can certainly share that information. We would like nothing more than for all of you to have your healthcare right here if you need to. So we can talk more about that. Maybe I'll talk about it on my address on Tuesday.
That's why the physicians are also retiring. My particular physician had 2,400 patients.
Yeah.
He goes into a primary care program for $2,000 a year, and then you'll be seen, and there'll only be 500 people within that plan.
Yeah.
It's
I mean,
pretty
it's a
interesting what's
problem.
going on in a medicine.
Yeah, the maximum per physician to be able to adequately be able to see their patient load generally is 700. So, yeah, there's no doubt the medical care field is challenged. Margaret had something, and Jeffrey.
If a single person is admitted to the health center, what happens to that person's independent living unit? Is it held open for him or her? Or is it closed up?
So typically the scenario is when it's a planned move, and we've been planning for it for months and so forth, the documents and the contract read that after you've moved, this is a permanent move. Like if it's one of these planned moves, like to assisted living, and then your family or you have 30 days to vacate that unit. So that's step one. When someone goes into skilled following a hospitalization or an illness, the interdisciplinary team discusses you at those Tuesday meetings, and you have care plan meetings with the care team, and we're discussing your discharge plans. What are your goals? And then we try to work with our rehab team to have you meet those goals. So if your goal is to get back to independent living, then that's our goal, and that's what the rehab team is doing. But with it, keeping in mind that you have to be able to meet the bottom part of that list of critical things. So for example, you could have every desire in the world to go back to your cottage, but if, let's say you've had some kind of a new diagnosis or something that creates where you need two people to assist you to get around, you can't go back to independent living with needing two people to assist you to get around. That's just a non-starter. But we really work through it. That's what the rehab process is for. So it's based on your individual goals. And then once a final decision has been made, we notify you. That's a very sensitive conversation. Some people come to the conclusion on their own or understand it. And then sometimes it's a harder conversation, but we apply those same criteria. I think Margaret had, and then I think we'll wrap up.
Mine is really an announcement because the Health Center Committee offers a tour of the health center once a month, most months. Our next one is on November the 18th, which is very shortly. We meet at 1:00. I meet, or one of us meets, everyone in the lobby of Independent Living. We escort you over to the health center, and then Natalie, who was mentioned as part of the interdisciplinary team, takes you on a tour. So you have a professional that does this. So I invite you to come. We will not have one in December, but it will start back again in January. And you can sign up at Concierge.
Thanks so much, Margaret. And thank you to all of you for coming. This has been recorded and will be on our YouTube channel, and we will tag it so it's one of the primary ones so it comes up on your feed if you go to our YouTube channel, and you can certainly share it with your loved ones so that they can understand the process as well. I know we've covered a lot of material, but it'll be there for you to reference. Okay, thank you so much.